Well, welcome everyone. Thank you for making it on this lovely yet ominous looking Thursday night. I was just informed that, at least for the St. Paul Public Schools, that there is a mental health awareness. It's Mental Health Awareness Month, I think, across the country, but today was the day to wear green in support of mental health awareness. And I thought, oh, how appropriate, because tonight we are covering mental health and trauma in our training tonight. So, today with us, we actually have a therapist. We get a little starstruck around her because she's a pretty popular colleague to have and great presenter. So I'm gonna get kind of nervous and maybe I'll flub her name. But with us today is Laura Oliveira. And before I say anything more about that, I'll let Laura kind of more fully describe her background here at Tubman. Take it away, Laura.
Thanks, Katie. You're so sweet, all of you, hyping me up. Yes, thanks, Katie. I'm Laura, everyone. Nice to be here with you all. I'm a mental health therapist. Like Katie said, I'm also the clinical supervisor at Tubman. So I see individual clients, do one of our DBT groups, and then I do a lot of work with our clinical mental health interns, supervising and getting them onboarded and going for their internships. So I have been at Tubman for 10 years, which always feels really long when I say that now. It's weird, but yeah, I've been here a while on the clinical team. So going to talk a little bit about some of the different things that we do, some of the services that we have, and then also talk through some skills, some hopefully supportive, helpful skills for interacting with clients. Yes, I'm sharing them from my perspective as a mental health therapist, but they're applicable for interacting with clients across different roles. So feel free to ask questions throughout. If there's time, we might have time at the end for questions too, but don't be afraid to unmute and ask questions or ask them in the chat. So plan for tonight, doing a little bit of what I just said, summary of services, helpful skills. We're going to talk about some definitions, more kind of in a discussion format, building some working definitions for mental health, chemical health, some trauma related terms. And then we'll have some scenarios towards the end where get to kind of think about what you would be thinking about in those situations and maybe some of how you would respond. So that's our plan. So let's jump right in and talk about some of the services that we offer and who we serve. So we on the chemical health clinical team, where we do some mental health and chemical health work, we tend to see mostly individual clients, and then we do a good amount of group work. And the individuals that we serve, we tend to see mostly adults. That's just who calls in for services most of the time. Every once in a while, some folks will call in to get their kiddo or their adolescent services, but not as often. And then same with couples and family therapy. So we tend to get mostly individual adults calling in. Tubman has such a reputation for doing domestic violence work, which we do. But on the clinical team, we're really a community mental health center. So, we do have some clients who are experiencing or have experienced domestic violence, but really the majority of our clients are experiencing a variety of mental health concerns, depression, anxiety, other types of trauma, um, bipolar disorders, relationship issues, other life stressors. So we really work with clients with a wide variety of presenting concerns as a community mental health center. So and then in addition to that, Tubman also has a reputation for working mostly with women. And we do still work with a lot of women, but again, right, in both in some of our other programs and in the clinical program, we work with clients across the gender spectrum. So, yeah, just kind of good to highlight some of those things because the reputation is strong, and thankfully it's good, but we also want to make sure it's accurate. So, so that's a little bit more about who we work with. Clients tend to find us. This question comes up a lot. Through, right, and again, sometimes that misconception is like we see clients in the shelter, and actually in the shelter they have a therapist over there, and the main clinical team that is out of the Chrysalis site on Chicago Avenue, our clients tend to find us through other providers in the Twin Cities, through insurance, and sometimes just kind of like general word of mouth. But I would say the two main referral sources are other providers that they've worked with. Maybe they're coming from a different type of program, like an intensive outpatient or, partial hospitalization program, and then they get recommended to us, or through their insurance. So yeah, that's who we work with, how they find us. Some of the other things that we do, in addition to a lot of individual therapy, we can do mental health assessments. These are typically like 1 or 2 times. Sometimes it takes 2 sessions to get all the information, but 1 or 2 time assessments. Sometimes those folks are like court ordered to get a mental health assessment. Other times people just self-refer because they want that information for themselves. So we do a clinical interview and write up a diagnostic assessment for those clients. And then we have one provider who is dual licensed, a mental health counselor, licensed professional clinical counselor, and licensed alcohol and drug counselor. So she does both, and she can see clients for for chemical health assessments in addition to the mental health stuff. So she can meet with clients, do a full assessment of their chemical health, and then refer them to a treatment program in the area to get more intensive chemical health treatment. So that's some of what we do. And then in addition to that, we do groups. We have multiple different groups. We have the Relationship Violence Intervention Program, and that has 2 groups. We have a men's group and a women's group. Most clients in this program are court ordered. Oftentimes they're on probation, and a part of their case plan is to complete a group like this. It's kind of like what used to be known as anger management, but we talk about much more than just managing anger. Psychoeducation on emotions, trauma, relationship skills, communication skills, psychoeducation on violence and abuse cycles, things like that. So very trauma informed. We do sometimes have clients in that program who are self-referred, who are not court ordered or court mandated to do the program, but majority of the time they are. So it's a great program. A lot of times people come in kind of resistant because they're being forced to be there, but then usually folks warm up and buy in and actually end up getting a lot out of it. So that's really great. So 2 different groups in that program. It meets once a week for a couple of hours. And then we have the Dialectical Behavior Therapy Program, also known as DBT. This DBT is a very evidence-based therapy, kind of born out of CBT, cognitive behavior therapy. And it is really, really effective for clients who struggle with regulating their emotions and maintaining stable and healthy close interpersonal relationships. So it was originally designed for people who struggled with borderline personality disorder, where those symptoms are often very intense, tumultuous, unstable relationships, difficulty with sense of self, and really intense emotional dysregulation, oftentimes leading to harmful behaviors. But it's come so far since then, and a lot of different clients seek out DBT. so many of us can benefit from additional skills to help regulate our emotions and navigate close relationships. So we get a lot of clients in there who have experienced trauma, some form of trauma, sometimes multiple forms of trauma, as well as clients struggling with depression, anxiety, different things. So really great program, really effective. It is long. It usually ends up being about 13 months long, and clients have the group once a week and then see an individual therapist and do the kind of individual components of DBT once a week. Um, so that's a little bit about that one. I will say right now, I'll say it again at the end, but you don't have to remember everything that I'm saying. Hopefully it's good information. Maybe some of it sticks, but it's a lot. It'll all be in your program guides. If sometime you're working with a client and one of these things pings and you think, oh, I feel like we might have something for that, but I'm not totally sure, you can always refer back to your program guide and it'll have everything that I'm saying and then a little bit more in there. But that's DBT. We also have a relapse prevention support hour. So this is kind of like a drop in. Some clients come regularly, other clients can just drop in and choose to just drop in. It's for anybody who is in recovery, committed to sobriety, and just would like some additional support. Maybe there was a recent relapse, maybe not. Maybe they're just wanting to get a little bit, not kind of go back into full programming, but get a little extra support. And this is a great option for that. Um, we have the trauma skills group. This group is taking a little bit of a pause. We didn't have a ton of clients for it. And so our clinical director who facilitates this one thought, let's take a pause, wait till we get more clients, build it back up, and then we'll start it again. So a little bit of a pause for trauma skills, but it's a great group. We've had it for a long time. And this is a little unique because it almost always has clients. There are so many clients seeking out a group like this. So really great group focusing on mindfulness, trauma resourcing, regulation, and starting to be able to track symptoms and implement resources that are really helpful for managing trauma symptoms. So those are some of our groups. We have a few more. We also have the Healthy Relationships group. It's a little bit similar in content to the Relationship Violence Intervention group because it does focus a lot on healthy relationships, relationship skills, boundaries, communication, but it is much less structured. This group, people usually are self-referred. They seek it out. There's not as much of kind of a clear, rigid curriculum like there is for the relationship violence intervention group. In that group, it's a check-in and then a specific topic every night that is built into a curriculum. Healthy relationships is more open. It's more open. Clients check in, process together a little bit, provide support to one another. And then if a theme or topic arises based on what clients are sharing, then they'll kind of dive a little bit deeper into that for the rest of group. So just a little different structure, even though the topics ends up being a good amount of overlap. And then the Expressions of Healing group is a kind of art-informed therapy group. It's not technically an art therapy group, but it's a group where they share and process together. And same thing, oftentimes there's kind of a different topic or theme, but then they do some art around that together, and then share about what that experience was like for them and anything that it brought up. So really cool group, Expressions of Healing. We have a chronic health conditions and disability group. And this one is a little bit more self-explanatory. It's exactly what it sounds like. It is a group to get support and sometimes, kind of ideas for skills and ways to manage chronic health conditions or disability. So really great resource. keep that in mind, keep that one in mind if you know someone who could benefit. Um, and then lastly, and I want to flag this one because it's unique to the others, the Melissa's Connections group. The Melissa's Connections group is a free drop-in support group. So all of the other groups, they do have a fee, but we take so many insurances, like almost all major insurances, including state insurance. So most clients are having their individual sessions and groups covered by insurance. Melissa's Connections, if you don't have insurance, doesn't matter. There's no, you don't even need to do an intake for it. And you don't have to commit to any amount of time. It's drop in, it's no commitment, it's no cost. It's just super low barrier to entry for anyone struggling with any aspect of mental health or chemical health. So, really fantastic resource. I just like to kind of highlight that one. And again, that'll be in your program guide as well. All right. So, along with being able to find information about all of these groups and services in your program guides, our intake department on the clinical team is also very helpful if you ever, look something up in the program guide and you still have a question, you can call intake. Chances are they'll be able to help. And they're also essentially a one-stop shop for getting registered for any of these services. So just one number where clients can call and get connected to any of the services that I just talked about. So our awesome intake team. Okay, I want to pause there. Any questions about any of that, any of the services that we offer? All right, sounds good. We'll keep it moving. Okay. So we are, that was a very slow fade. I could see both slides. Okay, let's talk a little bit about some of the terms that I've already been throwing around a lot, terms we've probably all heard and used, but we hear them in all kinds of different contexts. Mental health. Let's talk about that together. And during this portion, when we talk about mental health and chemical health, and trauma in terms of these definitions. We're gonna actually stop screen sharing. So if you're able, please feel free to come on camera so we can have a little bit of a discussion together and talk about what these mean and what we mean when we say mental health and chemical health and like what we look at when we're working with clients who are maybe struggling with mental health or chemical health. So, starting with mental health, what comes to mind? What comes to mind for you? You don't have to have a perfect full definition, but just what comes to mind when you hear the term mental health?
Uh, can you hear me okay?
Yes.
Hi. Uh, I know for me, I think a lot about like sort of like self-esteem and like how I think about and perceive myself, in terms of like my mental health and like how I take care of myself every day so that I'm in a place where I feel comfortable with myself. So that's how I conceptualize mental health and like my own mental health.
Yep, that's great. That's great. And it's sort of, I appreciate that because I think it speaks to this sort of duality where it's like the same things that we do to try to kind of promote and attend to our mental health are the same things that can suffer if our mental health is struggling, right? Or being negatively impacted by something. So it's, and that, right, that's sometimes part of what can make it difficult is like, oh, it's hard to do the things that actually help me feel better. So yeah, great. Thanks, Gabby. Yeah, thanks, Tara. The stigma shifting within the last 10 or so years. Yeah, it's been an interesting. kind of wave, right? I mean, that's like almost exactly the amount of time that I've been working in the field, and just the cultural attitude towards therapy 10 to 12 years ago, right? Before I started in the field to now is kind of wild, right? Kind of wild how much more present it is in, kind of the zeitgeist. So, yeah, ability to self-regulate thoughts and feelings. Yep, huge part of mental health. And I also see mental health can be good or bad. Seems like we talk more about the bad mental health than celebrating small wins as well. Absolutely. Yeah, I think that's true for the mental health and chemical health, right? Oftentimes we hear those and our mind automatically goes to, right, like mental health struggles or mental health problems or chemical health issues. But really, those are actually neutral terms, right? Mental health, chemical health, just kind of like what's our relationship to those things at any given point in time. So, absolutely appreciate that comment. Yeah, anything else? Anything else that comes up for anyone when you think about mental health? Yeah, stigma of mental health in different cultures. Yes, absolutely. I was just having a conversation with someone about that um, this morning, actually. So, um, yeah, even kind of around the attitude of like someone saying, I totally support it and I think therapy can work for other people and is good for other people, but just not for me. And there was some recognition that that was maybe informed by culture, right? Not quite yet being fully open to it for themselves. Yeah. The way the mind gives and receives messages. Yeah, I love that. That's great. Yep. Kind of our internal communication and how we're taking in information. Absolutely. Something that's very fluid. What good mental health looks like can vary for someone across time and might look different to different people. Yeah, definitely. Appreciate that comment a lot. Yeah, there's no, we do the best we can, right? We kind of need the DSM is important. It gives us shared language. It gives us, some amount of clarity, or it tries to give us some amount of clarity is maybe a more accurate way to say that. And yet it is so imperfect, right? Because humans are so complex. And oh, thanks, Joni. Sorry, yeah, the DSM. The DSM is the Diagnostic and Statistical Manual for Mental Health Conditions. So it's the big book that has all of the currently acknowledged mental health diagnoses and the different criteria that someone has to meet in order to be diagnosed with that condition. So thanks for that. And so, right, it's like the goal of that is to, try to kind of organize some of this and give us some shared language. And, but ultimately, someone said this to me once and it's always stuck with me. Diagnoses are descriptions, not explanations, right? They don't explain why, someone is the way they are or thinks the way they do or acts the way they do. They're, people we're experiencing different symptoms, different, ways of, again, thinking, feeling, different levels of distress. And then humans said, okay, let's try to look at these things that people are experiencing and then describe them with language, right? Kind of organize them into categories and describe them with language and kind of give a label so that we sort of know what we're talking about when we're referring to these different things. So I think that's kind of helpful to think about sometimes, right? These things were observable, and the language in the DSM is descriptive, it's not an explanation. So yes, people are complex, right? Language can only get us so far. Is the DSM universally used? Oh, you know what? That is a great question. And I'm going to be honest, I don't actually know. I don't know where all it is. Well, I think it must not be, I mean, probably for sure it's not, but it's even, I think, not used maybe even as widely as some would think, because there we have DSM codes, and those are the codes from the DSM, and then we have ICD codes. And I'm going to be honest, I don't even know what ICD stands for, but ICD codes are sometimes used even more often than the DSM codes. So I would imagine that there are probably some uh, countries where the DSM is maybe not used at all, and maybe the ICD is exclusively used. Like I know even at Tubman, when we code things, we actually use both the DSM codes and the ICD codes. So yeah, I would say more than likely not universally used. Is DSM to diagnose what a PDR to medication would be? PDR, it's not ringing a bell for me. International Classification of Diseases. Thank you, Amanda. See if I can remember that now. Royalty, I'm not sure. I'm not sure what PDR stands for in this context. So if you want to say a little more, I can see if I have an answer, but I might not. So I'll keep an eye out in case you want to say more about that. But yeah, so yeah, we've hit on oh, okay, physician desk reference. It describes medications in detail. Oh, okay, so is DSM to diagnosis what a PDR to medication would be? Yeah, I would say probably pretty similar. Just a little bit different, different because they're describing different things. And right, the DSM actually has kind of all of the symptoms listed out, but kind of similar in terms of like helpful to reference. It's kind of got it all in there, right? And they do even make like little, desk size DSMs. So yeah, good question. Okay. Oh, got it. Okay. So DSM is specific to mental health and ICD is everything. That must be a big book, bigger than the DSM. That's for sure. Okay. Great. So, yeah. So, mental health, we've hit on a lot of the important aspects of it, right? How we take care of ourselves, how we're able to function, our thoughts, our emotions, right? Many symptoms across many different mental health diagnoses, speak to difficulties in terms of our thoughts or our emotions. And, there's so many different diagnoses, there's so many different mental health conditions. The symptoms can really vary, but I think a helpful thing to think about when we talk about mental health, because like a few of you said, it can look so different. But sometimes what we look at is regardless of what the symptoms are those symptoms negatively impacting a person's functioning? And in different areas of life. And is that, and also are these symptoms causing distress, right? Subjective distress, right? So I think that's kind of an important takeaway is, mental health can look very different. The symptoms that we can struggle with can vary really, really widely. But if we are experiencing mental health symptoms that cause significant distress and are impairing our functioning, those are the times when right, we would probably say, okay, so this person's mental health is struggling, is maybe not very well right now, and they might meet criteria for a particular mental health condition if that's something that they want to, right? Some people want to seek out diagnosis, some don't. But that's the language that is consistent across every diagnosis in the DSM. And so I think that's kind of a helpful conceptualization when we think about mental health. Yeah. How are we functioning and how much distress are we in or not? It's nice when we're not. Okay, so same question. Let's switch gears. Same question for chemical health. What comes up when you think about the term chemical health? What comes to mind? Addiction. Great. Yes, addiction is a big aspect of chemical health. What else? Physical and psychological dependence. Great. Recovery. Yes. I'm going to switch to my seated setup here while folks are thinking. Resilience. Yeah, thanks, Jules. That's great. So much resilience in folks who are struggling with chemical health or in recovery. Yeah.
Something else that so fun fact about me, I'm a public health major and I'm in a substance use class right now. Is one thing we kind of talked about is chemical health and mental health are very much interlinked. So someone's experience with their mental health can be a risk factor or a protective factor in the relationship with their chemical health and vice versa. So there are types of health which are very much interconnected.
Yeah, absolutely. Thanks for saying that. Yeah, totally. And that's, that is why, most treatment programs nowadays are co-occurring disorders treatment programs, meaning that we are treating people for mental health and chemical health difficulties simultaneously. And it wasn't always like that. And that was a huge problem, right? For a long time, they were separate, they were siloed, and yet so many people, realistically, almost everyone who is struggling with one struggles with both. And people were going to one or the other and trying to get help, trying to get support. And then they would be told, oh, your mental health is in really rough shape. You should go work on that and then come back and we'll work on your chemical health. And then they would go try to, get support for their mental health. And they would say, well, your substance use is too big of an issue. You got to go work on that and then come back and we'll work on your mental health. And it's like that, right? Prevented a ton of people from getting better. So it's really good that has shifted and that both are seen as interconnected now, exactly like what you were saying, Gabby, and treated simultaneously, because that is definitely how it should be and is much more helpful. So yeah, this is great. We've got a really good working definition going in the chat. These are all aspects of chemical health, right? Someone's relationship to substances and substance use could be that they're struggling with addiction, could be that they're struggling with physical and psychological dependence on a substance, could be that they were, but now they're in recovery, and that's their relationship to substances right now, and that's where their chemical health is currently at. And there's a lot of resilience, like someone mentioned. Yep, they're functioning. We would look at that just like we were talking about with mental health. Royalty said obtaining help, coping skills, and support to eliminate the abuse of chemicals in one's life. Very well said. Yeah, how individuals are exposed to chemicals or substances. I like that. And then that language of someone's relationship to substances. Again, this actually pretty neutral definition, but just sometimes we think about when it's not going well. And then let's see. isn't it now ruled that you can't diagnose someone with a mental health disorder until they are in recovery, sobriety? I'm going to be honest, if that, I have not heard of that. I'm not saying that's not the case. I would be very surprised. That feels like we would be going backwards, big time. My understanding is that folks can be diagnosed with both. Yeah. There is, there is consideration to be made, and you'll sometimes even see this in the DSM. There are quite a few diagnoses where it will say, kind of under the criteria, or it'll list some symptoms, and then it will say these symptoms are not better explained by substance use. So it's not that you can't diagnose it. It's just that you want to make sure that you're assessing for that. And if the person is experiencing symptoms that could be related to a substance, especially one that maybe they are using or potentially using, then we would maybe hold off on giving that diagnosis until we can get a clearer picture. We would maybe just try to do more assessment and see if we can kind of parse that out. So definitely something to consider. Okay. All right. Great. I'm going to talk a little bit about trauma. We can keep the screen like this, but want to start getting into talking about and defining trauma a little bit. And I always like to start talking about this by pointing out that I think oftentimes trauma, that word gets used in one of two ways mainly. And one of them is sometimes when people say trauma, they are referring to a trauma or a traumatic event, right? They're referring to the traumatic experience that someone has had, right? Which is an experience. A traumatic experience is an experience that is so overwhelming or threatening and destabilizing that it overwhelms the nervous system. It overwhelms our defensive responses, sometimes even to the point of fearing for our own lives. That being said, I also want to point out that there are different types of trauma. There are those kind of big life-threatening or perceived life-threatening, well-being threatening experiences. But we also know now that there is attachment trauma or developmental trauma, which can be equally impactful and oftentimes occurs during childhood. And it might not be something as like explicit and obvious as different forms of abuse, for example. But something like chronic invalidation, chronic put downs, emotional unpredictability, things like that are, again, less obvious, less kind of immediately threatening to one's well-being, but are really damaging. And that is what is referred to as attachment trauma or developmental trauma. And those things, although sometimes less kind of obvious and immediately threatening, they are typically more pervasive. They may be more subtle, but a lot of times they happen every day or almost every day, and sometimes multiple times a day. They're woven into everyday interactions between children and their caregivers. And that is also part of what makes them so detrimental and so impactful. So I like to lift that up as well because it is so much more common than people realize. So sometimes when people refer to trauma, they're talking about like the trauma that happened, right? The traumatic experiences that happened. Other times when we use the word trauma, we're talking about how the person has been impacted and continues to be impacted by what happened, right? So it's not just what happened, it's also the long-term impact of what happened, because that is ultimately what makes something traumatic. Two people can experience the same thing, and it might even be something that a lot of us would look at objectively and say, oh, that's a traumatic event. um, but they can experience those things so differently, and one person might not continue to be impacted by that so there's no that trauma impact is not present right after the event has occurred, and then for the other person it is, right? So and then we wouldn't even necessarily need to say, oh, then that wasn't traumatic initially, right? But I'm just kind of speaking to, right? We can almost have like two separate definitions for this that are both totally valid, right? The trauma itself, and then the trauma, the impact of the trauma long term. Okay. So I think that's all really helpful to think about. And then the term trauma informed care, I think we see that a lot and hear that a lot. And I think it's helpful to think about, what does that mean? Trauma informed care is having at least a basic understanding, right? Ideally, maybe even a little extra, but having some understanding and education about trauma that we can use to better understand and more effectively work with the people and interact with the people who have experienced trauma. So we can weave that knowledge and understanding into our care, into how we are conceptualizing our clients as we are working with them, and then we can use that understanding and that information to be more responsive and be more effective in how we work with them. So that is trauma-informed care. Okay. Let's pull the slides back up and we'll keep going. All right. So we're going to talk a little bit more about trauma here and kind of break it down with this visual that helps us kind of simplify things a little bit. This is not a perfect diagram, or the brain is just so complex. So I just want to name that, like, this is not exact. This is not perfect. But it is representative, and I think it gives us a helpful way to think about some of this, and starts to give us that kind of foundation of understanding trauma and how it can impact people, so that we can use that in our work with our clients. So this is known as the triune brain. Breaks the brain down into 3 separate parts. And we've got, we'll start on the inside, smallest, lowest portion, right? The reptile image there, the white. So this is the least evolved part of our brain, and that's why it's given the nickname the reptile brain. This is very much a part of our brains as humans, but those structures in our brain, our brain stem, is very equivalent to the entire brain of a reptile. Or maybe I shouldn't say very equivalent, but the capacities that they have, right? So like reptiles, they don't have a limbic system or a prefrontal cortex. They only have what is our brainstem. And that's helpful to think about, because we can think about, what do reptiles, we wouldn't even say, what do they think about? They don't really think, right? They just do. And they just do based on survival, right? Reptiles' brains are concerned with automatic organ function to help keep them alive, eating, right? Getting their different basic needs met, going through processes that help them stay alive, and avoiding threats, right? Avoiding threats and trying to protect themselves when needed. So that is what our brainstem does. That's what our brainstem is wired for: survival, right? Doing the things we need to do to stay alive, keeping our bodies going, and avoiding threats and protecting ourselves when we need to. Important detail, I should say perceived threats. Sometimes there might not actually be a threat, but if we perceive it as a threat, still going to go into the brainstem, and that's what's going to kick in, and that's what we're going to be operating from. Okay, so brainstem, right, kind of lower innermost part of our brain, reptile brain, concerned with survival. Okay, that's what our brainstem is wired for. And then, right, the kind of next most evolved part of the brain, right? It's located in the midbrain, down kind of in there somewhere. And there's a cluster of structures known as the limbic system. And those structures, right, that make up the limbic system, we can nickname the mammal brain. Other mammals, other than just humans, also have a limbic system. They have these similar structures. And again, if we kind of go with the same analogy, like, okay, well, what can other mammals do? If you have a dog or a cat, what can they do? And what capacities do their brains have that a lizard doesn't? They can connect, right? And they can connect in more advanced ways. They're more social. They have more memories. They form attachments. They build communities and have social structures. They have greater capacity for emotion, not just survival-based fear, but sadness. And they say dogs don't have shame, but I don't believe that. I think anybody who has a dog has seen shame, but maybe it's a slightly different version. But yeah, sadness and joy. So they have greater capacity for emotion. And so we could also call this part of the brain the emotion brain, right? Brainstem is survival brain, limbic system, mammal brain is the emotion part of the brain. And that's significant, the fact that, right, emotion and memory and connection live there. That's significant. So we'll come back to that. But then the next part of the brain, right, the kind of overlay, and then this big part way up here behind our forehead is the prefrontal cortex, or the human brain, right? Because humans are the animals that have this part of the brain, the most evolved part of the brain. I do think there's some research to show that some other mammals have a little bit of a prefrontal cortex, but it is nowhere near as robust and evolved as ours as humans. So same question, if we keep going with the analogy, what can we as humans do that other mammals can't and that reptiles can't? Well, we have much more complex problem solving, right? Mammals can solve simple problems, but we can do layered, complex problem solving. We have self-awareness, much greater capacity for self-awareness. We have just way higher level executive functioning, right? We can think about thinking, right? We can go to that meta place and actually think about thinking. We can reason. We can weigh things out and consider all these different factors and possibilities and come to really thoughtful decisions about that. So, right, and that's really important. That's this part of the brain that can do all of those things, right? Really, really thoughtful thinking, we'll say. So that's the reasoning part of the brain, okay? So what does all of this have to do with trauma, right? I actually thought of this. I knew I had this coming up in a few days, and I let my dog out. I was letting my dog out a few days ago, and I let him out, and it happened twice in one day because this happens other times, but this day it happened twice in one day where he went out, and as soon as I opened the door, a rabbit came from like pretty close to the house and kind of bolted past the door and towards the tree and around the tree, and I assumed escaped through the fence. And it happened twice in one day. And I was like, man, that rabbit is really brave for continuing to come so close to the door, but limited capacity for memory. But I actually thought about this because I was like, there it is, right? That it's so fast, right? That rabbit went through really what is kind of a threat response, right? A threat response or a trauma response. So, right, through the brain, right, through sensory perception, right, here's the door, right, and probably has some memory, right, some memory there in the limbic system of what the sound of that door means. Dog is coming. um, and in an instant, right, it doesn't, the prefrontal cortex shuts down, right? And you know it does because the rabbit would not be able to get away, right? If the rabbit had a prefrontal cortex as evolved as we did, right? That's why this is so helpful for them. They just bolt, right? And we would do the same thing, right? Or we do the same thing because our prefrontal cortex shuts down, right? So the rabbit doesn't really have much of a prefrontal cortex. So limbic system just registers, right, some sensory information, right, perceives it as threat, and immediately, right, the limbic system shuts down, and that rabbit is in survival brain. That rabbit is in brainstem, and that's why it has just gone so fast. It happens so fast. And it's the same thing if you are walking across the street and all of a sudden you hear like tire, or you hear a car coming, right? And you don't even, right, you maybe look, or maybe you don't, maybe you literally just hear it. But either way, you perceive that information, and so quickly the limbic system is kind of the alarm system. So quickly, the limbic system says threat, danger, and sends the message to the prefrontal cortex to shut down. And the reason for that is the prefrontal cortex is too slow, right? But we'll talk about how this is a problem in other instances, right? But in this instance, it's so good because the prefrontal cortex would be way too slow. Just like if the rabbit had a prefrontal cortex, and if that prefrontal cortex stayed on, it would not be able to get away from my dog fast enough. So same thing, if we're walking across the street and all of a sudden there's a car coming, the brain works so fast to sound that alarm, shut down the prefrontal cortex, and divert blood flow and activity to the brainstem, right? The brainstem that is just wired for survival, where our defensive action responses, fight, flight, freeze, attachment, cry, collapse, where our defensive action responses live. And in this case, and again, we don't even think about it, right? The prefrontal cortex doesn't say, well, I'm about this many feet from that car, and it looks like it's probably going this many miles an hour. So, well, I could jump that way, or I could run this way, or I could, right? It doesn't think about that. And it doesn't think about, that my different ways I could protect myself. No, the prefrontal cortex would be way too slow. The brainstem just acts on survival, right? One of those defensive action responses kicks in, usually flight in this case, though sometimes not. Sometimes we freeze, right? The brain is too overwhelmed. It doesn't know what to do, right? We see that in movies sometimes, right? The person just freezes and then the car screeches to a halt right beforehand. But most of the time, the survival brain, the brainstem, is just going to say jump or run, right? And we just jump out of the way really fast. And we didn't think about it, right? Because we couldn't. There wouldn't be time. So that's the process that the brain goes through. Actual or perceived threat. Limbic system sounds the alarm and says threat, threat, danger, overwhelm. Tells the prefrontal cortex, shut down. You're too slow. You're not good at handling these situations. It'll be too late. Brainstem, turn on. Let's go and help us survive this threatening or overwhelming situation. And it happens in an instant, and it's not conscious, right? We don't choose for that to happen. It just happens. So when someone has experienced trauma, when someone has experienced trauma once, or when someone has grown up experiencing trauma, when someone has experienced multiple traumas, the brain has gone through this process again and again and again. And it gets more and more wired to do exactly this, right? Because it's like anything, right? We practice it, we do it more, we use any muscle in our body a certain way over and over again. It gets better and better, it gets stronger, it gets faster, right? So that pathway in the brain just gets more and more, more and more clear and easier to go down. And so people who have experienced trauma are more wired for this threat response, right? We're all wired to have, we have it for a reason because it protects us, like in the example I just used. But the more that the brain does that, right, the more it's wired to do it again and again. It becomes wired for threat, right? It becomes hypervigilant because it's trying to keep us safe. So then we're even more likely to perceive something as threatening even when it's not. Okay? So that's really important to understand about anyone who has experienced trauma. And a lot of our clients have experienced trauma. Most, if not all of them. And a lot of times different forms at multiple different points throughout life. So I always appreciate the last quote on this slide. Behavior isn't on purpose. Behavior is for a purpose. So sometimes, right, again, if we're talking about just perceived threat, not actual threat, but perceived threat, sometimes our clients might perceive something as threatening or be overwhelmed, right? And overwhelm feels threatening. Okay, that's important to remember too. Overwhelm feels threatening. So if our clients are overwhelmed, maybe feeling threatened, maybe both, their brain might be going through this process, and then they're not moving from their prefrontal cortex. They're not moving from their thinking, reasoning, sound, decision-making brain, right? The thoughtful thinking brain. They're moving from, in these instances, not all the time, but in these instances, moving from survival brain, right? And survival brain just says, get out of here, fight back, protect yourself, do whatever you need to do to feel safe or be safe or not be overwhelmed anymore. And sometimes those behaviors can be difficult, right? Sometimes those behaviors can seem really out of place or uncalled for, right? Because of perceived threat, right? We might be able to recognize like, oh, everything's okay. There's no threat here. But in that, right, if that was the perception, and then this is the process that the brain goes through, it doesn't matter. So those behaviors that you might see and the ways that a client might be interacting, especially if they're having a trauma response, those behaviors might be difficult. You might be getting kind of like lashed out at, or the client might be getting a little bit escalated, or they might just hang up the phone, or, get up and storm out, or something like that, right? Fight response, flight response. And that's not on purpose, right? It's not on purpose. It's not intentional. It's not personal. It's for a purpose. And that purpose is to just try to feel safe, right? And to just try to not feel so overwhelmed or so threatened. So, really, really helpful to try to keep in mind when working with clients, and especially just knowing that, we work with a population that has experienced a lot of trauma. Okay. So, as we keep going here, we're going to just do one more section and then we're going to take a break. So, I feel like I'm running a little behind, so I'm going to try to be efficient with these next couple slides. So, these are skills that are helpful across the board. Whatever your role is, anytime you're working with clients, these are things that are going to be helpful if you're talking with clients. And some of these might seem basic. That's okay. That's great. Good. I hope some of them do. And that being said, just because they're basic doesn't mean that they're not important. In this first one, active listening is a great example of that. That might feel super obvious, right? To actively listen when you're talking with clients, to try to make some eye contact, nod along, give some of those cues that convey presence, asking open-ended questions, giving them space to talk. That might seem obvious, and that doesn't mean that it's not impactful, because for some of our clients truly don't have anyone in their lives who actively listen to them. Some do, but some don't, and we don't always know. So this can actually be very impactful and really help clients feel seen and heard and safe. And then this next one, contact statements, maybe a little bit less familiar. And this is letting the client know that you are letting the client know that you are recognizing something about their experience. This says that they are having emotions. It might be more than just emotions. It's just contacting some part of their experience and letting them know that you're tracking that. Making emotional contact with something that they are experiencing. So, a contact statement might be something like, I'm noticing blank, right? Like I'm noticing that your voice went up when you started talking about X, right? This situation. And so just kind of gently naming an experience that you're noticing, whether it be an emotion or something else, can be really helpful. Even just like it sounds like this is really hard, or it sounds like this is really frustrating. That could be a contact statement. So these are simple, oftentimes short and sweet, but can really make people feel seen and help build rapport. And then reflecting back what the client is saying. So actually doing a little bit of paraphrasing and verbally reflecting back some of what you're hearing. Same thing, shows that you're tracking, you're present, and sometimes can be a good way to sort of summarize and then say, am I missing something, right? So reflecting back what you heard and then saying, am I missing anything? Is there anything that I forgot? And just giving them space to add anything else that might feel important. Okay, and then validation. Validation is any statement that conveys to the client, you are important. What you are saying is important. You are, your experience matters. Your experience is real. What you are feeling matters and is meaningful, is valid, right? That is validation. So, I can see why you feel so angry. I can understand why you're so frustrated. That really makes sense. Those are validating statements. And there's a note here about kind of avoiding joining, or we could say avoiding validating if something is not. So emotions are always valid, right? That's their experience. That is their real experience. That is always going to be valid. But if there is an interpretation or a perception or a belief along with that emotion that, maybe is not accurate, because sometimes our perceptions are not accurate, our interpretations are not accurate. Sometimes we have like maladaptive beliefs that formed for reasons that make a lot of sense but aren't always true. Something like everyone is out to get me, or no one cares about me, or something like that. Or, nothing is going to work, right? Those are thoughts, beliefs, perceptions that we might not want to validate, right? Because we don't want to co-sign something that could actually be harmful, but we can validate the emotion that is underneath that or alongside that. Be present, right? We talked about active listening because it conveys presence. We also want to try to really be present, right? Not just act like we're present, but be present and keep our attention in the here and now and track what the client is saying and feeling and experiencing. We're human. We're going to get distracted sometimes. That's okay. That happens. We just want to try to come back. And then lastly, be curious about underlying needs. Another way to think about that is like themes. Like if a client is talking and they've mentioned a few different things and it's starting to feel like, oh, there's a theme here. There's a thread that connects these, and it feels like there's stability missing or there's connection missing. Sometimes it's helpful to name that and kind of like lift that up as a theme and saying, I feel like I'm hearing this in all of these different things. Does that feel right? And is that maybe something that we could work on? So kind of listen for those underlying needs or themes. All right. I think that brings us to a little break. So yeah, let's take a break. Joni, how long, Joni and Katie, were you thinking? 5-minute break? Anything, Joni or Katie, anything before we keep rolling? Okay, sounds good. All right, let's do a quick poll. So what comes up for you when you think about being in a high intensity situation or crisis situation with a client? You can check multiple things. So take a second, think about this, and whatever resonates, check those and submit. Okay. All right, so we've got the results here. And I do actually always like to look at this, and it's really common almost every time. You've got almost everything has been endorsed, and almost everything, if not everything, has been has been said multiple times. And I think that's the case here, which I think just goes to show that these are all really valid responses and thoughts and feelings to have when thinking about being in a crisis situation. They can be nerve-wracking, they can be difficult, so it's really normal to feel nervous. It's really understandable to ask the question, right? Am I going to feel threatened or unsafe? Will I have help if I need it? That's a really big one. These situations are difficult, and ideally, we do have help if we need it. We're going to talk a little bit more about that. Um, Do I have the tools that I need to handle that? Another really common response. And I think, and I would imagine a lot of people did check off multiple things. I know I do, and I still feel multiple of these things when I think about being in a crisis situation. So, we can feel mostly confident in navigating something like this and still feel a little nervous, or also wonder, am I going to have help if I need it? So these all really make sense, every single one of them. And hopefully, what we talk about tonight will address some of these. We're going to talk about some tools. We're going to talk about the importance of, grounding and resourcing ourselves and taking care of ourselves and making sure we know how to get help, if we need it. So, thank you all for participating in that. I do think it's usually pretty illustrative. So, so let's jump in and talk about some of those skills, for when there is a crisis situation or just a situation where there's some activation and escalation present. So, the skills we talked about right before break, those are in no particular order. You can use all of those kind of interchangeably whenever. These are intended to be as in order as they can be. So, kind of think about these in chronological order. All right. And that's how I'm going to talk about them. So, as soon as we become aware that there is some kind of crisis, either right here or nearby, the first thing that we want to do whenever possible is do a little bit of grounding for ourselves. Check in with ourselves, even if we just have if we have 5 seconds or if we have 30 seconds or whatever. Do a quick check-in, right? Just go inside, feel your own body, take a deep breath. You can push your feet into the floor. That can be really helpful. Actually feel the ground underneath you. I'm doing this even as I'm talking about it. I'm not even thinking about that, right? So I put self-soothe on here. Think about, do you have anything that helps you self-soothe? For a lot of people, just making some self-contact. It might be right here on your heart. It might be on your abdomen while you take a breath. It might be, right? Maybe it's like, oh, feel my own hands, feel my own skin, like tiny bit of self massage, right? Just little bit of sensory self-soothing can be really helpful. Know if you have any of your own kind of little tricks that tend to work for you, and do those things. That's what we want to do first, because if you think back to the brain diagram, or a visual, right? We want our prefrontal cortex online. We want to have our prefrontal cortex online because we're going to go try to navigate a difficult situation, and we need our thinking, reasoning brain online. So really helpful for us to do a little bit of grounding. Take some deep breaths. Nice, slow, deep breaths. Longer exhale than inhale helps activate the parasympathetic nervous system, which is the part of our nervous system that helps us calm down. So even just that, even just a deep breath or two with a longer exhale can help keep that prefrontal cortex online. So that's first, grounding for ourselves, right? Next thing we're going to do and try to be aware of is our nonverbal communication, right? So same thing, you go back to that brain visual, right? The person is wired for threat. And if they're already in crisis or escalated, they are even more hypervigilant to anything that appears threatening. So what can appear threatening, right? When someone is in an activated state or not? Loud voices, harsh tone, big body language that might seem aggressive, blocking exits, right? That can, right? We're more likely to feel trapped if we are in a dysregulated state and if we're in our brainstem, survival brain. So those are the kinds of things we want to really try to be aware of. Our nonverbals and our paraverbals, our tone, our volume, our posture, what level we're at. So if the person, I remember one time someone was really dysregulated. I think they're having a little bit of a panic attack, and they were on the floor. And I walked over slowly, and I just got like all the way down so that I wasn't standing here towering over them. So those kinds of things are helpful, right? Making sure we're not blocking an exit so that, right, their brain doesn't go, I'm trapped, I'm trapped, things like that. So that's what we want to do next, right? Um, After that, first thing we want to focus on, especially once we start actually like talking and interacting with them more directly, is we want to focus on regulation. Sometimes there is a really understandable urge oftentimes to jump into problem solving, like, okay, what happened and how can we fix it? If somebody is in a dysregulated state, uh, oftentimes they can't engage in that because, again, prefrontal cortex is offline. So, what we need to really focus on first is regulation and getting the rest of the brain back online. Then we can try to do some problem solving, right? But first, it's just about regulation. It's just about bringing down, right, the physiological distress, the emotional distress, and just helping the client feel a little bit more safe and regulated in this moment. Um, and so we can offer some options really gently, not too many, because we don't want to overwhelm them, right? Again, prefrontal cortex is offline. It's hard to sort through a bunch of information, but we can sometimes just offer one or two options, right? So we might say, okay, let's focus. We could even say that. Like I would maybe just say that to a client, right? It seems like this is feeling really, really hard, right? This is a hard state to be in. Let's just first focus on regulation. So what is there anything we can help you do to just feel a little bit more okay right now? Do you want a drink of water? Do you want to step outside together, get a little bit of air, right? Just offering a couple of gentle options like that. Do you want to sit down together, right? Um, might not get if they're in a dysregulated state, there might be some pushback initially. That's okay, right? Try to stay, try to stay steady, right? Um, if they get loud, right, we want to keep our voice low. One, because we don't want to appear, threatening, but also there's a natural, right? If we get louder, then they're just going to get louder. And then we go up and up and up, right? If we stay low, if we even kind of hush our voices a little bit, sometimes there's that acts as kind of this natural pull, right? And actually brings the other person down with us. So even if they stay, right, even if they don't come down with us right away, stay there, right? Stay steady, right? And again, try to focus on your own regulation. Co-regulation is really powerful, right? That co-regulation is that right brain to right brain connection. And if we can connect, if someone can connect with us, if I'm in a dysregulated state and someone who has a regulated nervous system can connect with me in that moment, their regulated nervous system actually helps to regulate my nervous system. That's co-regulation, right? That's why when we're with little kids, if a little kid gets really upset and is, kind of throwing a little bit of a tantrum, if we then start doing the same thing back, right, the whole thing just goes off the rails. But if we just stay calm and steady, we can help that little one regulate, right, with our calm nervous system. So really thinking about that throughout, right, even if the person doesn't come down right away. So offer some options and just for a little bit focus just on regulation. Okay. Next thing we want to do is then we might get into, right, we could do this in a couple different ways, helping the client identify existing skills and resources. We could do that as a part of focusing on regulation. So another thing in addition to that question, is there anything we can do to try to make you feel just a little safer right now, just to try to make you feel just a little bit more okay right now? Sometimes it's helpful to ask, what do you do other times? Because clients have resources. Clients are resilient, right? They usually have some skills, even if they don't realize it. So sometimes it can be helpful, right? If we can offer some options, sometimes that's a little bit easier because it might be hard for them to think of stuff. But sometimes if we say, I imagine you've had difficult moments before. What do you do? What do you do that helps you get through these moments? Sometimes the client can go, I do this thing that really helps me. And we could say, okay, what if we try that a little bit? Um, we could also do this if the client has regulated a bit. We can use this same kind of strengths-based um, approach with if we do start to get into trying to problem solve whatever the thing was that kind of caused the initial activation or dysregulation. So maybe there is kind of a concrete issue. And sometimes it's helpful to say, like, hey, have you ever navigated anything like this before? Have you been in? And sometimes they haven't, but sometimes they have. So it's okay to just ask. And if there is anything that was helpful in the past, maybe we can try that. So giving some credit to the client's strengths. Know your limits and continue to assess the situation. So this is the only one that, if we, in terms of chronological order, this one we actually kind of want to be doing throughout, right? We could sort of put this, we wouldn't because it would make the slides super junked up and disorganized, but we could sort of put this one between every single other bullet point. Know your limits, assess the situation. Know your limits, assess the situation, right? At every point. And if at any point you know for sure you need some help, ask for help. It's totally okay. Even if you're not sure, even if you're kind of on the fence. There have been times where, I'm in the building and I hear something and I can tell, oh, there's something going on down the hall or downstairs. Even though I feel pretty confident and I know someone else might be there and I might be the help, if I see one of my colleagues on the way there, if their door is open, right, and they didn't, I might say, like, hey, let's go check this out and see what's going on. So it's totally okay and encouraged to, get someone else involved. These are hard situations. They can be nerve-wracking and kind of activating for all of us. So the more prefrontal cortexes we have present, the better, right? So totally okay to get help. And on that note, we'll talk about this a little bit more, but we want to know who we're supposed to go to, who all we can go to, and how to reach them in situations like this. So, and then lastly, debrief. I really can't emphasize that enough. I'm not trying to be melodramatic. So important to debrief. Um, you know, Crisis situations are stressful. They are stressful and activating for us and our nervous systems. And depending on what it is and how significant it is, vicarious trauma is real, right? We talked about trauma, vicarious trauma, secondary trauma, from being exposed to different things, from being exposed to the things that our clients are experiencing, and from navigating sometimes really intense situations. So one of the ways that we can protect ourselves against vicarious trauma and burnout is to debrief afterwards, right? We give ourselves that chance to process what happened so that it doesn't just stay inside and get stored and all knotted up, and then manifest later in ways that can be really difficult. So debrief, debrief, debrief with a supervisor or a colleague, or someone in your life that feels safe and supportive. Okay. Let's take another breath here. Always good to do after talking about crisis and de-escalation. And just a couple of quick notes on client safety. Most of you are in a role where, you're not going to be doing an in-depth safety assessment. Some of you are, and if you are, we're going to talk more about that in other spaces, not here tonight, because most of you are not going to be in that kind of role. But you might be working with clients who are experiencing safety concerns and who maybe are at risk of self-harm potentially. If you are in that situation, and even though you're not going to do a full safety assessment, if you have concerns about that, gently ask the client, gently but clearly, right? Are you thinking about hurting yourself? Do you feel unsafe? Do you feel like you can keep yourself safe? Are you worried that you can't keep yourself safe? Right? Something clear and direct, but gentle like that. You don't have to be worried about asking that question. It is better to ask that question if you're noticing, some things that make you worried about that than to not ask that question. Other than that, right, you're not expected to do more assessment beyond that. But if the answer is yes, just know your team's protocol. Know who you're supposed to reach out to in that situation, how to reach that person, when it's something urgent. We all are oftentimes wearing different hats and doing all kinds of things. Who all can you reach out to? Ideally, you have multiple people you can reach out to, and the fastest way to reach them if there is ever something emergent. So whether it's a colleague or a supervisor, or someone else's supervisor, even if it's not your direct supervisor, we want to have options for who we can reach out to. So if that information isn't given to you, please ask, and make sure you know who to go to and how to reach them. There are some good crisis resources. COPE for Hennepin County is really great. They can do safety assessments with clients. They can come out and see clients in the community and help them figure out if they need to get some additional support. 988 if you're in another county other than Hennepin County. And then clients can go to any local emergency room. So that's just stuff that's good to know. And then in addition to that, if if anything like that comes up, just try to remember some of the things. You can employ some of the same things we talked about with de-escalation. Respond calmly, use some of those de-escalation skills like grounding yourself, right? Being gentle, being mindful of your tone and your demeanor, offer options, and give the client appropriate space. That can be a vulnerable thing to talk about. They might feel a little bit overwhelmed, so we want to use some of those same de-escalation skills. And then last note on this, if there's no immediate safety concern, you could still make a referral to a supportive mental health service, whether it's through Tubman or somewhere else. You can look at the program guide, and it's always okay to tell a client, there are services out there. There are services here through Tubman. There are outside services if you would prefer that. It's totally their choice, right? We don't want to push that on them. But yeah, even if there's no safety concern, it's okay to make a referral if it seems like there's some mental health difficulty going on. All right. So last thing we're going to do is just talk about a couple of scenarios. So I will read through this, and then, it says at the bottom, and this is intentional, what might you take into consideration? So you don't have to have, this is what I would do, but just what would you be thinking about? How would you be, tying in some of what we talked about tonight, as you, if you were in this situation and thinking about what's happening here. So you're talking with a client about housing resources. Upon being given a list of options, the client becomes upset and states she has already tried those avenues with no success. She becomes tearful and begins to raise her voice, saying no one will help her and that the system treats her unfairly and this is hopeless. What are some of the things that you might be thinking about if you were experiencing this with a client? And if part of that is, how you might respond, that's okay too. Sorry, Gabby, you're cutting out a bit. I can't quite make out what you're saying.
Uh, my like computer mic loves to be finicky.
Oh,
One thing that like I'm thinking of is like, well, like it'd probably be good to like affirm the fact that like it is that like that does sound like a very like a struggle. Like that issue is reasonable to feel like frustrated if like you've gone through all those options and like things just haven't worked out. Making sure that like the like thought the like interpretation of that as like it's hopeless and she will like never ever get help or that like those type that interpretation of what she's been through, making sure like maybe not to affirm that part of it because like there is like we want to hopefully like provide some amount of hope or like at least affirm that like her feelings are valid, but maybe not like the interpretation that like no one will ever help her because we are trying to help hopefully or like hopefully like there's another interpretation of that maybe we can help get to. But I think kind of making sure that if like we're using affirmation to be careful about what we're affirming in this situation.
yep. Very well said. Yep, spot on. Yeah, validation would be really, really helpful in this situation, but we want to be mindful about what we are validating, right? And it sounds like there is frustration and some hopelessness here, right? And we want to validate the emotion and that this is really hard and she's frustrated and she's discouraged, right? And that makes so much sense. And also probably that it feels overwhelming, right? It seems like that's maybe kind of where the activation and escalation is coming from in this moment. Um, but yes, we want to try to be careful not to invalidate the interpretation that like there is no help and nothing will work. Yeah, great. Anything anybody wants to add? Yeah, the only other thing I would add is just that, in that response, we would want to be mindful of some of those de-escalation skills, specifically like our nonverbals and our paraverbals, because, right, we can see, oh, there's some escalation happening. So we would really want to try to regulate our nervous system and use a really calm tone of voice and see if we can help kind of anchor her a little bit. I just want to look at these couple of chat responses as well. Yeah, focus on de-escalation. Yep, exactly. Um, what need is being unmet? Yeah, I think that's a good question in this case, right? Um, Making sure to respond in a call. Yeah, yeah, we were saying the same thing at the same time, definitely. Yeah, and the need being what need is being unmet is a great question. Yep. In this case, it could be some different things, right? I could see it being she's just not feeling supported, right? Like so far the help hasn't come. And that is a need, right? Support is a need. Um, or maybe it is the hope, right? Like it's just so hard to have hope. So yeah, good question to ask. What is the need that's going unmet? Hmm. Yeah, housing, which is basic needs, right? Stability, right? Basic needs and stability. Okay, great. Let's go ahead and do the next one. All right, you are with a small group of children in the children's center. A 4-year-old boy hits one of the other children. When you attempt to intervene and address the behavior, he yells at you and then he runs away to hide under a table. Same question. What might you be taking into consideration in this situation? Okay, someone said I would get down to his level under the table in the most unthreatening way possible. Yeah, and talk calm. Yep, so that, right, idea, let's get down, right? Kids are always getting towered over, and that alone can be scary, right? Maybe just us trying to address and correct the behavior, even if we tried to be gentle, maybe us standing way up here, that might have still felt threatening. So, yeah, getting down on his level. Yep. And Leah not crowding him. Great. Yep. Still giving space. focusing on regulation. Yeah, developmental trauma. Yeah, maybe he's right. This could absolutely be a trauma response, right? And so even though we weren't trying to be threatening, right, and we weren't actually threatening when we corrected the behavior, it might have been perceived as a threat. And then he has a defensive action response and runs away to hide and be safe. Flight. And yeah, maybe this is how he has seen people solve problems in the past. Yeah. And I don't know if that's in reference to the the running away or the initial hitting, but it could apply to both, right? This could all be learned behavior. Mm-hmm. Yeah, I appreciate that comment, Gabby, keeping a calm tone of voice even if he's yelling, right? Or even though he's yelling again, right? Remembering that actually if we stay down here, that's going to be more likely to pull his activation down with us in a good way. Yeah, acknowledge the fact that he might be afraid. Yep, probably, right? We usually don't run away to hide under a table if we're not afraid. Yeah. And try to speak softly and be comforting. Yes. Yeah. Great job. Yep. All that's spot on. I think those are all the things that we would want to be thinking about, right? Thinking about what's happening for him inside, not taking it personal, not, just trying to kind of get bigger and correct more. Like, okay, let's slow down. Let's slow down and try to meet him in a different way. Great job. Okay. All right. So the next couple slides, and you have these, there are just some additional resources. There's some crisis lines, websites with more information on some of what we talked about tonight. There are some books. A lot of times people would be asking for book recommendations, so we just put some of those on here if you're interested. And then I think that's it. Except that's my dog that I talked about. So I'm surprised you didn't hear him at all tonight. He's been very good. No barking. So um, yeah, but that's it. Thanks everybody. Thanks for participating and yeah, contributing to the discussion.